Dr. Bonnie Miller, the Senior Associate Dean for Health Sciences Education and Executive Vice President for Educational Affairs at Vanderbilt University School of Medicine. She's talking about early results from the Immersion Phase, a new post-clerkship curriculum at Vanderbilt.
I want to thank you for the opportunity to speak about this, and I'm thinking that maybe results is the wrong word, but we do have one graduating class already from our new curriculum. I do want to thank an incredibly talented team, and actually Bill Cottrell is here and up next, and he co-led the team that created the Immersion Phase. And also I want to thank the AMA for support through that Accelerating Change in Education grant. So outline, I want to talk a little bit about Curriculum 2.0, its background, structure of the Immersion Phase, how we've used milestones, and these are our own School of Medicine milestones in the Immersion Phase and throughout the curriculum, and then close with some thoughts. I really wouldn't call them conclusions. So we began our curriculum revision process in 2010, and this is the same Julio Frank paper that Eric mentioned this morning, with this idea that linking that education, health professions education, should be linked to the needs of the health system, not just the healthcare system, but the health system, and that importantly, they should both be derived from the needs of the population. We also were very strongly influenced by Dave Irby, Molly Cook, Bridget O'Brien's Educating Physicians, published by the Carnegie Foundation in 2010, the 4 I's, individualization, integration, inquiry, improvement, and identity formation, and really embraced these and the principles of Curriculum 2.0. So we kind of put this together as we were planning the curriculum. What is it that we're aiming for? And using individualized pathways through medical school, we made a commitment to competency-based education and also to content areas that emphasized a systems approach to patient-centered care. Again, kind of the health system science, a real commitment to that content thread. Importantly, we said that our outcome, our ideal outcome, would be a critically thinking, self-assessing, self-directed, self-regulating, lifelong workplace learner who's committed to leading change. And I love the phrase in the Frank paper. They said that really the purpose of education in the 21st century health profession should be the creation of enlightened change agents. And so we really are after the creation of enlightened change agents. So this was the first iteration. This was the design that we presented to a large group of faculty in August 2010, and you can see, let's make sure this works, a single pre-clerkship year, which is now called Foundations of Medical Knowledge, the core clinical year in the second year, and then a 2-year post-clerkship phase that we actually call the Immersion Phase here. We have longitudinal elements. This has become our learning communities, and interprofessional continuity clinical experience has become a course now that we call Foundations of Healthcare Delivery. We didn't plan this necessarily with a 3-year pathway in mind, but we did know that it would be possible. And in fact, our MD-PhD program, or MSTP, does have a 3-year MD program and 4 years devoted to the graduate phase, so that this first group of students, MD-PhD students that matriculated in 2013, should be able to finish in 7 years instead of 8. So this is the final form of Curriculum 2.0. And we've made lots of changes along the way that are probably a little bit more detailed than you can see in this picture, certainly based on our experience and lots of user feedback. But the basic structure has remained the same. So I'm going to focus a bit now on the Immersion Phase. When we started the design and planning phase process, we had a general idea of what we wanted to do and where we wanted to go, but we thought that it would be very important to actually clearly articulate what the goals of this phase would be. And you can see the goals right here. Oh, sorry. And I think some of them are very familiar. Some of them are unique to Curriculum 2.0. Number 4, to ensure readiness for intern and residency. I guess you could say that really all 7 really are readiness for internship and residency. We designed course formats that were specific for each of those goals. And they really vary across 2 different spectra. One is workplace learning versus kind of more formal didactic learning, and the other is single discipline versus multidisciplinary. So for example, for our integrated science courses, when we shortened the pre-clerkship phase to 1 year, we did make a commitment that we would come back to basic science or foundational knowledge in the immersion phase. And so these are courses that have a blend of didactic time and clinic-based learning or workplace-based learning. They're also usually multidisciplinary and taught in teams. The acting internship really is focused on that prep for residency and TENS prep. It is almost entirely workplace-based and single discipline. So here's our menu of integrated science courses just out of, just for information. You can see most of them are interdisciplinary, really kind of not based on, say, medicine, surgery, but really following different processes across different care settings and really taking a different kind of look at these areas. These were somewhat determined by faculty interest, but actually we commissioned a great number of them, which was a little different for us as well, based on what we thought were curricular gaps and curricular needs. So students are required to take a certain number of each of these kinds of courses, and I will also echo George and say this isn't science. This is our best guess. They're each required to take 4 of the integrated science courses, an acting internship, a certain number of these advanced clinical experiences, and they're also required to have a 3 to 6 month research experience during that immersion phase. Again, this was kind of a negotiation. Those of us who were involved in this process had different opinions about what it should be, but this is where we landed and seems to be working so far. Now, students work with portfolio coaches, as George described. These are very similar kinds of coaches throughout the 4 years, and they make their selections based on both their interests and also what are perceived to be their gaps in knowledge or performance. Even with that, again, this is a coached, guided process. We were still really very interested in how the students kind of approached this opportunity to put their own curriculum together. We've started recording some stories, some narratives, and hopefully at some point we'll have the opportunity to do some analysis with this. So before the first class matriculated, Kim Lomas, our Associate Dean for UME, who's working with the Core EPA project as well, worked with a standing assessment committee to develop milestones for our competencies within competency domains, so the same nomenclature that George described. This required a tremendous amount of work. They range from undesirable, unacceptable level, even entry, and then what we are calling aspirational. And when faculty members use forms like this, there's also the ability to kind of put the student in between one level or the next. These forms are used across all settings, so these are really the workplace-based assessment forms. They're used for self-assessment, peer assessment, faculty assessment, so it really does give us the ability to collect a lot of data over time. They're collected and compiled in electronic portfolios. Susan mentioned earlier this morning VSTAR, and this allows us to really show the progress of students over time. We had in mind sort of pediatric growth curves, and it looks something like that. So I'm going to show results. This is for one of our excellent 2017 graduates. So this is a kind of not a random selection. This is a student, a grad that we knew was doing very well. The red line here shows what our faculty designated as target for graduation. You can see here in patient care, PC2, the student started entry level and moves up here towards the end with kind of a leveling off here between the third and fourth year. Medical knowledge 2, same thing. It's interesting. Again, this shows some variability, I think probably in assessors using the form as much as anything. That even early on here we had the student reaching aspirational levels. It's hard to imagine. But importantly here towards the end of the fourth year, and again, we really think this is a great student, having some assessments here with lower levels. Again, in interpersonal communication skills, same kind of pattern, gradually moving up, leveling off here at the third to fourth year, and some outlier data points. And finally, professionalism 1, really the same pattern for this student. Now, we have about 23 different milestone forms for competencies, and we actually break these down into sub-competencies. And one of the questions you can ask, that this is data for one of our really good students, is it discriminating? If we showed data for a student that we knew wasn't quite as strong, would it look different? And the answer is yes. We've looked at some of these. Again, this is at this point not well analyzed. These are really pictures and kind of our just our take on what it looks like. We have a tremendous amount of data analysis yet to do. We've started to aggregate these over entire classes. So this is the competency that we saw here for this student. This is the entire class assessed on that competency over time. With this student, again, you see kind of this leveling off and kind of hits the graduation target level relatively consistently at the end of the third year. For the class as a whole, you see the line kind of crossing the target somewhere in the middle of the fourth year. Now, what we really need to be able to do is show to the individual curves, and all of this, it would be very, very messy, but I really think that's important. What we'd like to be able to do is maybe be able to see what is the trajectory each student is on. Is there a point, I think this is similar to what Stan showed early this morning with some of the, I think, emergency medicine data, was it? That you can see where students or where graduates kind of fall off the curve. Can we make an early intervention? But more importantly, can we detect students who are on an accelerated pathway already, regardless of the curriculum that we're giving them? So in other words, do we detect an accelerated pathway in our students rather than define that accelerated curriculum for them? So what does it all mean? Lots and lots of questions. The more that we look at this data, I think the more questions we have. How good is it, as everybody said today? The validity, the impact of inter-rater variability, how we definitely have very, very well-trained faculty assessors and others who have been using the forms that are not quite as familiar with even the competency-based paradigm. Do students grow in other very important dimensions that we don't capture with our milestones? Are our scales adequate? The reason that they level off is because aspirational is too low. Are we underestimating our students? Again, are we identifying a point at which the students really need the MD degree in order to grow further? Or does our curriculum really allow for them to continue to grow? Again, are we holding them back? Can we confidently identify at a point at which students are safe, and along with that, what kind of variability at the end there can we tolerate? When do those outlier points become signal instead of noise? And how important is the metadata in that situation? I showed screenshots in the actual live kind of web-based version. You can hover over each data point and find out something about the difficulty of the patient. Was this a very difficult encounter? So there's more there that we need to understand. Then another question, and this may be kind of heretical in this particular gathering, but is the only purpose of UME preparation for GME. This is a picture of a program that we put together. It's a PhD to MD program based kind of on what Columbia did, except that we are looking for PhDs in engineering or informatics. We thought that we wanted to be able to provide them with a curriculum that would allow them to graduate in 3 years, but when we thought about all of the kind of fun things that we could do for this particular cohort, we realized that we couldn't do that in a 3-year curriculum. So they have a design lab, they have an industry internship, and it's a very unique cohort, and we felt that we came to a decision point and felt that being able to provide this experience was more important than the 3-year pathway. So some concluding thoughts. I'm confident, and I think this group in general here today is confident that we can identify a group of students who can and should graduate in less than 4 years. However, there are opportunities for enrichment and enhancement in a 4-year curriculum that could be sacrificed. But on the other hand, is it worth the cost? And as Joan said, $250,000 if we actually told our students what it was costing them very explicitly to have that wonderful 4th year of enrichment and leadership and research additional, would they choose it? On the other hand, can we adequately cover all of these new content areas, everything that we've tried to do with system science and health policy? Can we do that well in a shorter curriculum? And then finally, again, this is kind of preaching to the choir and stating the obvious, but a continuum approach is not just important, it's essential. If we feel that there are things we don't need to do in UME, we've got to be pretty confident that they're going to be picked up at the GME phase of the curriculum. So again, thank you for the opportunity to present this, and questions later.